feeling of going to the toilet after meal, we learn how to suppress it. The kids, they don't. So utilize that reflex. So make them sit in the toilet after major meal 2 to 3 times a day. Initially there will be no response. After 2 to 3 weeks they will start passing stool after meal. So that needs to be stressed. And don't overstress this toilet training in very young kid. After 2.5 to 3 years only they learn how to do it. Before 3 years it may be detrimental. Sandhya, the common problem, like the child I presented, the 2 weeks therapy responded, mother discontinued therapy, again constipation. So what should be the duration of therapy?
This can be a difficult one, but when in my personal practice, I say that you're likely to require some form of medication for the same length of time that you've had problems. So if this child has had significant problems from 6 months, it probably was building up before then. So in this child, I would say you are likely to need something like 6 to 9 months of treatment.
Yep.
If you do a shorter form, yes, the child will be fine for a short time, but the likelihood is if they don't do major interventions with addressing the stool holding or the diet, the symptoms will come back.
Yep.
Compliance is an issue depending on the age group, but the pegylated glycol, you know, the unflavoured one, you can put drops of squash in, so the children usually can drink it, but it's the issue of the families getting it all the time.
Yep. You will agree with me, Kamakar sir, that in the first go, you have to tell the parents, see, you need to give at least 6 months. That should be the minimum criteria. It may take longer than that. Otherwise, what they do, this child is invariably going to improve with your whatever you give, milk of magnesia, lactulose, but they tend to stop. And that is the main reason. Early withdrawal of laxative is the commonest cause for recurrence. That's why you give a tentative schedule that initially I'll do monthly follow-up till this bowel movement is regular, 1 to 2, and then you give the same dose of laxative for at least 3 months. That is the time required for the colon to come back to normal and function properly. Like in gastric outlet obstruction, before surgery you do lavas 48 hours, 72 hours till the tones come back. Same thing happened to the rectum. It's become mega rectum, hugely distended. Function is gone. So you have to give that much of time for regaining of the tone and proper functioning. So you need to explain that. That's the important issue. Recurrence after successful treatment, you have treated for 6 months, 1 year, and then gradually stop. How often you get recurrence, India? Is it common, uncommon?
If they are adherent to treatment, then actually you get good response. It's the non-adherence that it causes the problems. You will get minor, particularly what you try and do is to cut down the maintenance doses, so you may have a minor thing, and the thing is to educate the parents that, look, don't keep an eye on the stools. If you see a change in pattern, you can increase the dose slightly for a short time, and it's educating the parents as well, and it may be just a temporary increase for a week or 2 weeks and then back down again will help.
So it is quite often you get recurrence after stopping, and you can treat them with shorter duration. Usual outcomes, Sandhya, what prognosis will you give it to your parents when they are coming with functional constipation? You are telling, yes, you have to take this treatment for 6 months, 1 year, but what happened after that?
Well, according to your slide, the younger ones, the majority recover. The older age group.
No, just basically this all 30%. It is difficult to control.
More than half will be fine. There is a small select group that will be troublesome, and they are the ones that will perhaps need further investigations with my GI motility colleague, or that it's to do with adherence, etc. So a small proportion will have significant problems.
Yeah, what I want to say that in 2/3 of the cases you achieve whatever you want to achieve, but around 1/3 of the cases it is difficult. Like this long-term study say that 8 years, 80% are successful, but overall it's almost 1/3 of the cases they have a very prolonged course. The index case follow-up we have at 1 month, 3 months and 6 months after starting treatment on polyethylene glycol, passing 1 to 2 soft stool in sitting position, no encopresis, no withholding maneuver, diet change to solid from predominantly milk. She gained 1 kilo and 3 centimeter, and our plan is to slowly taper the polyethylene glycol. Actually, from India we don't have much publication. Karmakar sir, this is the study we published from SGPGA recently, Indian Pediatrics, where we have given this statement. This statement may be wrong. This is totally our statement. That pediatrician, we don't have any scientific basis for that. This is our assumption. Pediatrician from this subcontinent believe that functional constipation is uncommon. In developing countries, as our diet is different than the developed country, it is rich in fiber. In day-to-day life, we eat a lot of fiber, so that is the perception. Hence, many cases of constipation are subject to, whenever they come to, though you may be exception, they are always our concentration is for Hirschsprung disease, because we believe that functional is not common. So, what is your opinion about it?
I fully agree with you. Firstly, I mean, you can't say in our country that, our country is many countries. We have people having diets which are highly westernized, and we are having people in smaller rural populations who probably have a more healthier diet than we have. So you can't say in our country it's all uniform. So we still see a lot of cases with dietary constipation. In my practice, I think maybe 1 in every 25 would maybe need, I don't know the exact number, but may need some further tests.
Okay, so you believe that majority are functional. So this is in our study also we said from India that in West they said 90% functional, in our figure it is 85%. Though we are practicing a tertiary care referral hospital, SGPGI, despite that, probably in the community it will be much more. So it is India also your 80 to 90% are functional. So no need to believe that everything is Hirschsprung, but we do see Hirschsprung disease. Professor Jhankaria sir, I will give you some barium and you need to first can you tell us that when you are suspecting Hirschsprung, what are the precautions we should take before doing barium? Because there is a common mistake we do.
I think the first and foremost is that when you suspect doing a barium enema for a suspected Hirschsprung disease, we must take the plain X-ray of the abdomen first.
Sir.
That is very important to know whether there is up to what level there is a gaseous distension in the large bowel, whether the rectum is empty or rectum is loaded with fecal matter. And number 2 is that no purgatives, no preparation should be done with the patient.
This is very important.
No preparation should be done, and whatever the patient comes, he should do it. And third is that while doing the barium enema, only a thin rubber tube just put at the anal verge, and then inject the barium. And as soon as the barium enters the rectum, turn the patient in lateral position. So anorectal junction is very clearly outlined. So that way, it's and once the barium it fills the rectum, stop the barium.
Yes, sir. This very important issues Professor Jhankaria has highlighted, because normal tendency is that do barium after preparation, give enema and then to get a better view. But in Hirschsprung disease, if you give enema before barium enema, you lose the opportunity to get the diagnosis. Sir, this is that plain X-ray. Can you just give some? I will give you this pointer.
We can see the marked gaseous distension with air fluid levels. From the hostel pattern, you see this is a colon which is distended. And you all know that whenever there is a distension of the bowel loop, the small bowel loops will show multiple spring coil-like appearance, while in the colon there will be very few hostations and there is a large air fluid level. You can't see anything here in the lower down, it is over fluid. Here also the same thing.
Right, sir. So the Professor Jhankaria has highlighted the importance of plain X-ray also. That will give you clue what you are dealing with. Sir, this is the barium enema of a classical Hirschsprung disease patient.
Yeah. Now this is just a tube at the anorectal junction, anal verge, and you can see the narrowing of this area, rectum and the rectosigmoid junction. Then there is a marked proximal dilatation with the full of fecal matter. So this is a classical case of a Hirschsprung disease. And whenever but one thing is to remember, even though you can see a normal caliber sometimes and you do not rule out Hirschsprung disease, this is one thing to remember. So this is definitely a narrowed segment, a ganglionic segment. Rectum is always more distended than the sigmoid normally. The diameter of the rectum is more than the sigmoid normally. So this is a very
Sir, this is a very important point, I suppose, that reversal of ratio. Normally, ampulla of the rectum is the widest part. So if you get a reversal, means sigmoid is wider than the rectum, think about Hirschsprung disease. See this case, what sir has suggested, the rectum is narrowed, sigmoid is wide, total dilated. So this is one of the classical point need to be emphasized. Sir, that the panel on your side, can you just give us a little bit about different types according to the length, like classical, short, ultra short, and total?
Now, as Dr. Karmakar said, once I just put a tube at the end, just anal verge, and you see a small segment, and then all of a sudden you see dilated rectum. We call it a very ultra short segment.
Yeah.
And of course, the short segment, you get anorectal junction. The
Yeah.
most common cause is that the anorectal junction is about 1.5 to 3 centimeters. Then, of course, a long segment, it can go anywhere into the
Yes.
sigmoid. Even the transverse colon can be affected.
Yeah.
There can be sometimes the skip segments also may be seen.
So I'll show you, sir, this is probably total
So
colonic
the entire-
aganglionosis.
Yeah, it's an entire microcolon sort of thing. You can
Yes,
see
sir.
that.
And I'll show you one more picture, sir. This is a newborn with. I borrowed this slide from my pediatric surgery colleague, Dr. Richalal. And this is the, sir, another barium. Is like what they say, comma-shaped colon, suggestive of total colonic aganglionosis.
Yeah. This
She has said that this is total colonic aganglionosis. I believe her.
It's not distending fully.
Yeah,
It's entire
yes, sir.
colon is. And this
So
is a
she
narrow
said
segment.
that probably question mark, sorry, not comma, question mark
Rectum is
shaped
distended.
barium. Rectum is distended, but the rest of the colon
Rest
is.
of the colon is
Yes, sir.
normal.
Right, sir. Sir, what
This-
about this?
This is, I would
barium?
call it just an ultra short segment, just.
Sir, can it be acquired megacolon? See, this is a big question about this ultra short, because many people believe that this may not be a true case of Hirschsprung disease. There may be a just acquired. This may be acquired megacolon.
It is possible. It is possible.
With this kind of picture.
See, this is just a fecal matter, which is, and then
Yes,
there is
sir.
all rectum is distended right up to the anorectal junction.
Sir, this is a very important, interesting observation, or we get the report from radiologist that retention of barium in the rectum after 24 hours suggestive of Hirschsprung disease. So, what is your comment about that? All of us have experience. You are sent.
I wouldn't say straightway Hirschsprung disease, but I would say there is no emptying of the colon after 24 hours. So whatever the cause, we have to find out. But it is one of the Hirschsprung disease, one of the cause.
Yes, sir. But if you don't get that classical picture of transition zone, just this retention of barium suggests Hirschsprung.
No.
Sir Karmakar, sir, will you highlight? This is a really important issue.
No, I think we are all taught, when you're taught about this, that take a delayed film and check for retention, but it's very fallacious.
Yeah, exactly.
You might have a fecalith in which some barium gets impregnated and which remains there after 24 hours. So I think it's not at all of any consequence.
Rajesh, in a child with constipation, when will you suspect motility disorder as a cause? Routinely, like the case I showed, we manage all right, but when will you suspect we need to investigate for motility disorder?
So I think if somebody doesn't respond to simple line of treatment,
Yes.
like your polyethylene glycol or lactulose, especially I look for any, like not for motility, means even Hirschsprung's is in a way a motility
Yeah,
disorder.
yeah, that's true.
So if you have any red flag signs, failure to thrive especially, nausea, vomiting, diarrhea, not diarrhea, nausea, vomiting or failure to thrive, then my threshold for doing tests is much lower. That's
So
what I would-
basically the refractory cases, when you are
Refractory.
treating, not responding, you have tried your everything for 6 months, then you should think about motility disorder. Can you broadly categorize that according to the transit study or motility pattern wise, can you classify?
So you can have
constipation?
somebody with either a transit disorder or a pelvic floor dysfunction,
Very
or
good.
you can have a combination of two.
Yes.
So you can have somebody with slow transit, or somebody with dysynergia that I had discussed yesterday, so he's unable to expel.
Yes, yes.
But we see that people with functional disorder, at least 30% means a functional defecation disorder like pelvic floor dysfunction, may also be associated with a slow transit. So just because you have a defecation problem, that doesn't mean you cannot also have associated slow transit. I definitely, before I label them, I would, like the tests you had mentioned, calcium, thyroid, these are the things I would definitely rule out before I label them as a slow transit.
Transit constipation. Ma'am, Shobna, this is basically manometry tracing I borrowed from Dr. Ghoshal. Can you just read it for us? This is basically to look for recto-anal inhibitory reflex, how to do it, how to interpret, and what is the implication of rectal manometry, manometry.
Just a little orientation. The tube is put from the anal canal into the rectum, and because in the esophagus, when we put in the tube, the LES is lower and the esophagus and the nasopharynx is on top. In the rectum also the same thing happens, that when you put the tube in, the deepest part actually becomes the rectum. Actually it should be the other way around, that's okay. So these 3 ports are in the sphincter. 1, 2, 3 ports are in the sphincter. This is in the rectum, and once the basal pressure is measured, after that what we do is we inflate a balloon in the rectum. Now when you inflate the balloon in the rectum, this is what happens inside the rectum. The pressure goes up, and as the pressure goes up, what you expect to happen is that the external sphincter should contract, as is happening here. This is the external sphincter. It contracts, and the internal sphincter should relax. Now the reason that there are 3 ports here is that these 3 ports are very near each other, and therefore you have 3 recording ports which are looking at the internal sphincter. There's one in the external sphincter and one inside the rectum. So essentially what you see is this is the baseline pressure. When the pressure drops when the balloon is distended, here the pressure rises, and the pressure in the external sphincter should increase. So this is a normal, what you call as a recto-anal inhibitory reflex.
And this one?
This one, the same thing. I think there's a little, I can't see the port where the balloon is put.
The lower one is the rectum, and then
so the lower one again is in the rectum, but I think it's already slipped into the sphincter. But if you see this, when you're inflating the balloon, this is not really touching the baseline. So there is an incomplete RAI on all these. It is not just touching the baseline, and the external sphincter is probably not well recorded here either.
So this absence of recto-anal inhibitory reflex
is suggestive of reflux.
So basically it is a ruling out. If you get RAIR present, that rules out Haspang, but absent may or may not.
That is
what
the
are
thing,
the fallacies, ma'am, in interpreting this RAIR?
One is that if the rectum is very, very large, if the rectum is, you have to have an empty rectum in order to be able to do an RAIR. In contrast to what Dr. Jankaria said, that you need to do an unprepared colon for the barium. For doing a manometry, you need a prepared rectum at least. And in very small children, for example, in infants, you can go wrong because in an immature child, you might get RAIR which is not normal because the neural connections are not yet mature. But whereas as when in a full-term normal delivery, you expect that the rectal inhibitory reflex should be normal. That is one of the reasons. Second thing is that in a large rectum, if your balloon is not inflated, if you have a balloon for 20, 30 or 40 ml, and it doesn't really fill up the rectum and does not increase the rectal pressure, then this RAIR is not going to be seen. Also in very small babies, you can do away with just 1 ml of air injection. You don't have to actually put in a full balloon in order to be able to do an RAIR.
Karmakar sir, clinical tips to differentiate functional from Haspang, very important for pediatrician. You just can...
Right, I think you've highlighted most of them.
Yes, sir.
Starting from delayed passage of meconium at birth.
Yes, sir.
To onset, which is late in cases of functional constipation. Encopresis is more common in functional, and all the other points.
And sir, rectal examination.
Yes.
we want to stress that you need to do a peer examination, even if to differentiate empty versus the stool. Ma'am, Shobna, biofeedback therapy, how to do it and its role in the management of refractory functional constipation?
I'll just first let me go through the basics. That biofeedback therapy is something that you teach a child to see what is happening. Not only a child, this can be even done in adult, to see what is happening when he is trying to do a maneuver for passing stools, and then train him to see what should happen. So this is very important in patients who have dyssynergia. In other causes of functional constipation, it's not so useful. It's very useful in dyssynergia. What happens in dyssynergia is that when the child is trying to pass stools, instead of the internal and the anal sphincter relaxing, both of them contract. And that is what you were talking about, the various maneuvers that the child does. So normally, when there is an urge to pass stools, the internal sphincter relaxes, but if there is no opportunity, the external sphincter will contract. Whereas in dyssynergia, as I said, both will contract. So what you do is, when you put in a recording probe inside, which will look at the internal sphincter as well as the internal sphincter, and there is a diagrammatic representation. So this is the stool, and when the child contracts his internal sphincter as well as internal sphincter, this stool remains inside. Internal sphincter is contracted, the stool remains inside, but his external sphincter has relaxed. So that time you tell him that this is still better than contracting both. And ultimately, when he tries to relax both the sphincters, you see that diagrammatically it shows that the stool is actually coming out. And then it kind of gives him kind of bonus points and things while the exercises are being taught. So this is exactly, and it is useful, but it is an extremely tedious procedure. You require to sit with the child for at least 1 hour at a time, at least twice or thrice a week initially, before they show any kind of response. In at least 10 to 12 sessions are required initially, right. And maybe about 50 to 60% of dyssynergias do respond.
Right. Thank you, ma'am. The last question, sir. This is not we practice frequently, like appendicocecostomy and antegrade continence enema, probably in a setting of refractory constipation with frequent troublesome encopresis. Sir, I downloaded the slide. Can you just highlight to the crowd that what exactly we do?
Sure. I think this is again a very useful procedure when used in properly selected situations, and it's very underused in our country, but it's a very effective way of giving a complete enema or a washout. And because the conventional enemas given per anal, per rectally are a retrograde kind of evacuation, but here we are talking of something which evacuates the entire colon starting from the cecum, and that is what is known by antegrade continence enema. This procedure was first started by a surgeon called Maloney's. So in our parlor it's called MACE, M-A-C-E. That's the Maloney's antegrade continence enema. And here we can use the appendix, which is quite conveniently attached to the cecum, and bring one end out on the skin surface. It's a tiny invisible stoma, which is a continent stoma, so no stools leaks out, but you can put the enema catheter from that appendicular stoma and give a complete washout of the entire colon, as is shown here. I use these very often in management of bowel incontinence,
Yes.
which I see a lot in the spina bifida group.
Right.
And it's a procedure which we are increasingly doing, and it really makes the daily procedure of giving enema so easy, and the child becomes self-dependent, does not have to be dependent on somebody for the enema.
Thank you, sir. I think we have discussed most of the thing. Thank you all.
I'll be talking on transjugular liver biopsy, which is a very close to my heart, this topic, because I remember when we started it with ABBA somewhere in 1997, 98. We started it, and then we've never looked back beyond that. And what is more important is that doing transjugular biopsy is no big deal. But when you're doing it in the pediatric age group, it's a totally different ball game. So when you're doing a transjugular liver biopsy or TIPS, it is important that you are very well aware of the anatomy of the liver and which is the area you need to target. And if you do not have this knowledge, it is quite likely that you can cause more damage than get benefit out of the procedure. So basically we are looking at the anatomy, and if you see, we are going from the right hepatic vein when we are doing a transjugular liver biopsy and entering into the most bulkiest area of the liver, so there is less chances that you can perforate the liver or go through the capsule. And diagrammatically, if you see, you are coming in from the transjugular route, you are entering to the right hepatic vein and making a passage which is usually slightly anterior. So that is again is a big area of the liver. Even if the patient has cirrhosis, you have a good bulk of liver that you can get a chunk from the true cut biopsy. So what are the indications in the pediatric age group to do a transjugular liver biopsy? I for one feel that first and most important is if the biopsy is possible percutaneously as we normally conventionally do, that's the best way to go, is the least invasive. But in certain circumstances that is not possible. And which are those? Those are when there is a coagulopathy, 2, when there is gross ascites and you cannot manage to trap the abdomen dry for the percutaneous biopsy. You have thrombocytopenia, and when you have a real small liver post cirrhosis and you have a failed percutaneous biopsy. So these are the main indications for doing a transjugular liver biopsy. Obviously we are coming from the vascular route and remaining in the vascular route, so the coagulopathy and the ascites does not matter when you are doing a transjugular liver biopsy. What is the material that we require? These are the commercially available material that is available with a company called Cook to do a transjugular liver biopsy. I have modified our own technique to come down on the size of the catheters because it's the pediatric age group. Otherwise, all these biopsy equipment that is available for adults, and we are using them for children. But we are using different, which I'll just come back to you later and show you what is the material we are using. But this is the commercially available set for the transjugular liver biopsy. What is important is that in the pediatric age group, the less punctures you have, the better it is, and it is always advisable 99.9% of the time that you use ultrasound guidance to puncture the jugular vein. The anatomy of the jugular vein, we all know, is very close to the carotid artery, and we don't want to puncture the carotid artery. So ultrasound guidance is the way to go to puncture the jugular vein. Excuse me. This is the diagrammatic representation. You are coming from the jugular vein, you enter into the SVC through the RA, come into the IVC and enter into the right hepatic vein. It is always better to use a true cut. That is why the results of transjugular liver biopsy are much better than just an aspiration cytology. You are entering into the hepatic vein and perforating the hepatic vein and coming into the liver parenchyma and taking out a true cut piece. And this is what the profile of the transjugular liver biopsy needle looks like, the tip which takes out the chunk of the liver tissue. So what is the technique that we follow? We're using a 6 French braided sheath to puncture the jugular vein and enter into the IVC. Use a cannula, use a multi-purpose catheter to cannulate the right hepatic vein. Once you have entered the right hepatic vein, you confirm that you are in the right hepatic vein and advance the 6 French braided sheath into the right hepatic vein. Once we have achieved that, all we have to do now is take the transjugular liver biopsy needle, which is sheathed over a 6 French catheter which protects the tip so that you don't perforate the sheath or you don't perforate any of the structures while you are introducing the needle. A picture showing you the sheath. This is the round tip of the sheath which is in the hepatic vein. You have confirmed that you are in the right hepatic vein. You advance the transjugular liver biopsy, trigger it, you get a piece, and after you finish the procedure, it is always a must that you do a hepatic venogram to check whether there is any fistula, whether you have perforated any structure where you need to do something about it. That could be a hepatic artery, it could be a portal vein. Most of the time they heal by themselves, but if it is the artery, usually it does not and develops a pseudoaneurysm, and you might have to treat it immediately. So comparing aspiration to true cut, this is, I've just done a search, and which shows that in aspiration the success rate of getting good tissue for histopathology is 68%, whereas in true cut it is 97%. So what are the complications of a transjugular liver biopsy? Common whenever you are puncturing any vessel, you can have an access site hematoma. Capsular puncture, as I said, if you do not know which is the alignment, which is the position of the liver, you can go through and through the capsule, and that could be a problem. So that is why, again, showing you here, it is important to note that to what extent you can go, your throw of the needle would be. So remember that you cannot go beyond this point, because then that is where the capsule is, and you can have a lot of bleeding intra-abdominal if you are not careful of that. You can have hemophilia, which most of the time settles down, but if it is because of perforation of a hepatic artery, that could be a problem. Fistulas, maybe with the portal vein, is seen, but usually if you wait for some time and do an ultrasound, you'll see that these fistulas close off by themselves. So that was to do with transjugular liver biopsies. Now coming to the other venous interventions, basically I'm going to talk on tips, but before you can go on to tips, it is always important that we talk of Budd-Chiari syndrome also, because that is a precursor to tips. If it is possible for us to do a hepatic vein dilatation and restore the liver function to a certain extent, you can quite avoid doing a tips. But before I come to that, the olden days, what we used to do was, when endoscopy was not so well advanced, we used to have patients with intractable variceal bleeds and could not be controlled. We used to go transhepatic, go into the portal vein and embolize the varix. As we can see here, we have gone into the portal vein, and this is the huge varix that you're seeing going up to the esophagus, and we have coil embolized the whole varix. That is just to show you the history. Now, when you're talking about Budd-Chiari, it is always better to try and revascularize as many of the hepatic veins as possible, if not at least one. This is a 6-month-old child with intractable ascites. USG showed massive ascites, and Doppler was normal, which we very often see today. That, I think, is because either it's the lack of awareness or lack of knowledge of the sonologist to what to look for in Budd-Chiari syndrome. Remember this color Doppler of the liver showed that all the hepatic veins were normal. You're seeing here there's a tight stenosis. There is no flow into the IVC, suggesting that there is a tight stenosis. You are seeing collaterals developed here. We put in a balloon dilated, and final result is very good. This was for the right hepatic vein, and looking at the middle hepatic vein, again the same story, a tight stenosis of the hepatic vein junction with the IVC, again balloon dilated it, and finally you no longer see these collaterals fitting, and you're seeing good antegrade flow into the IVC. Saying that a part of Budd-Chiari is the IVC membrane. If these can be treated, then you are trying to avoid doing a TIPS procedure. This is a tight IVC membrane. We have put in a balloon dilated it. This is pre and post. You are seeing good flow across. These are very rewarding procedures, and the child improves pretty drastically immediately after the procedure. Now finally, coming to the TIPS procedure, we all know it's transjugular intrahepatic portosystemic shunt. Now, which are the indications for doing TIPS procedures? When there is portal hypertension complicated with chronic variceal bleed, not controlled by sclerotherapy or other endoscopic procedures, hypersplenism with thrombocytopenia, biliary atresia awaiting transplant, cystic fibrosis with portal hypertension, again waiting for liver transplant. In my opinion, I think the main reason why anybody would do a TIPS would be as a bridge to transplant, or if it is like a life-saving procedure, patient is bleeding profusely, cannot be controlled on endoscopy, or he is having gross ascites and is in an emaciated condition, that is the time when you would do a TIPS. Now, why is that so? It's basically because there is no dedicated pediatric stent graft available for TIPS. So when there is no stent graft available, why are the results of TIPS suddenly increased is because of this stent graft that is available, which is called the Viator stent. With that, the patency rate is gone up to as high as 95% after 3 years, which is very, very good. But this is not extrapolated in the pediatric age group because you don't have that stent. So then what do you use for doing a TIPS procedure in a pediatric age group? We normally use a regular stent. We can use a stent graft, but again that stent graft is not a dedicated stent graft for TIPS. So we are using regular stents, and when you are using regular stents, the same problem arises as any other stent in the body where there is restenosis or thrombosis. Other thing is that because we are using a small size stent, as the child grows, the child outgrows that stent that you have implanted. So that becomes small, and it is difficult for us to, after a period of time, to balloon dilate it again. Because, again, everybody is not that experienced in doing TIPS in children, the success rate is also much less. It's about 60 to 80%. And as I just mentioned, the primary patency rates of the